Good afternoon. My name is Jaz Aliwalia. I'm a professor in the School of Public Health in the Alfred Medical School. I serve as Deputy Director of Cadre, an NIH-funded COBRI grant focusing on substance use and chronic disease. I'm joined by our Cadre Principal Investigator and Director of the Center for Alcohol and Addiction Studies, Peter Monti, and Jennifer Tidy, Director of the Clinical Lab Corps and Associate Dean of Research at the School of Public Health. The Distinguished Visiting Scholar Series was designed to bring prominent cutting-edge investigators to Brown for formal presentation and informal meetings. We are absolutely delighted to have Neil Benowitz presenting on Is There a Role for Nicotine in Society? Comparisons with Alcohol and Cannabis. Neil is Emeritus Professor of Medicine in the Research Program in Clinical Pharmacology, Division of Cardiology at the University of California, San Francisco. For those that are familiar with the term emeritus, it usually means you're playing golf. Neil is not playing golf. He actually works just as hard as he was when he was not emeritus, and that's a separate story that you can ask him about how that works and why it works. I can give you the short version of the intro. It's very simple. Neil is top 5 in the world in the area of tobacco, cancer biomarkers, and nicotine metabolism and kinetics. Second intro piece for him is simply he's also top 5 nicest person in the world that I know. And that's pretty much the bottom line. But if you wanted a bit more, he's chief of the Division of Clinical Pharmacology and Experimental Therapeutics for 35 years. He received his MD from Rochester School of Medicine in '69, served as resident at Bronx Municipal Hospital Center, which I think informed his commitment to health equity. He then completed a postdoc fellowship at UCSF in clinical pharmacology and joined the faculty. That would be now 48 years ago at UCSF. His research interests have focused primarily on pharmacology and toxicology of nicotine. He's published more than 700 research papers and is still very active publishing. He's an active clinician as well in cardiovascular medicine and medical technology. There's sort of this whole list of things he's done. Just to give you a flavor of it, he was scientific editor of the 88 U.S. Surgeon General's Report on Smoking and Health, Nicotine Addiction, scientific editor of the NCI Monograph on smoking and yields of tar and nicotine. He's section editor of the 2010 Surgeon General's Report. He's a member of the, was a member of the NIH study section on pharmacology, and affectionately known, he was also on the TPSAC, the FDA TPSAC Committee, Tobacco Product Science Advisory Committee a few years back. He served as president of SR&T, as many of us know, and also American Society for Clinical Pharmacology. He's received numerous awards, including the Alfred Ochsner Award, the Ole Ferner Award, Hunter Memorial Award in Therapeutics, and the list goes on. In 2002, he received the annual Distinguished UCSF Clinical Research Lecturer. So just a quick reminder, the event is being recorded. It is hybrid. There are more people on Zoom that are here. We believe, yes, in fact, it's confirmed that people on Zoom can post Q&A in the Q&A session, and Hillary is monitoring the Q&A, and we'll repeat the question out loud. So without further ado, please join me in a warm welcome to Neil Benowitz.
Okay, well, thanks very much, Jaz. It's great. This is the first time to be at Brown University, and I'm so glad to come here because I've worked with many of the people here in the past for years without ever having to see where you guys actually live. So thanks for inviting me. So this is the first time I've given this talk, and the reason I'm doing it is because I usually speak to either people in tobacco or medical people, but I haven't really spoken to a broad substance abuse group. And I wanted to address this question, which is sort of a social philosophical question of what should be the role of nicotine in society after cigarettes. And so that's going to be the broad topic. The reason I thought about this came from a lecture I gave in Warsaw on nicotine addiction like 3 or 4 years ago, where after the talk, a physician came up to me and said, I used to be a cigarette smoker. I'm now vaping. I like the nicotine. I think the risks are reasonable. And I object to being termed addicted. I think this is my choice, and I want to use this. And I think this is a reasonable thing for me to do, and what do I think about it? And so it did make me rethink the question about what does addiction mean, especially if someone is well informed. These are my disclosures. I do consult with some pharmaceutical companies and have been involved in tobacco litigation against the tobacco companies. This is interesting. This is sort of my background. So I was trained as a postdoctoral fellow in clinical pharmacology, which is really human research on the pharmacologic effects of drugs and cardiovascular disease. My first job after I finished was working with Rhys Jones, who's a professor at UCSF, studying the cardiovascular pharmacology of cannabis. So I did that for a couple of years. But then I realized from my cardiovascular practice that the real inhaled drug that was a problem was not cannabis, it was tobacco. So then at that time there was very little systematic research on the clinical pharmacology of nicotine, so I decided to set up a laboratory to begin studying nicotine like it was a drug and its cardiovascular effects. So I spent most of my career studying nicotine. Now I'm back to studying cannabis and nicotine together in combination. So this was really the beginning of my career. So I'm going to talk about a variety of areas. Some of it's going to be science, some of it's going to be more policy related. So I'll talk about nicotine pharmacology. I want to talk about the continuum of risk, which is an important question. The harm from nicotine in youth, cigarette smoking and nicotine-based harm reduction, the comparative benefits and risks of nicotine, alcohol, and cannabis, and then the question of the role of nicotine in society. So this is where I want to try to go. So first, what does nicotine do? I want to give you a little bit of pharmacology. I don't know how much you know about it, but let me just tell you about nicotine addiction. So the first, nicotine works in the body because it's got structural similarities to acetylcholine, which, as you know, is a major neurotransmitter. And it affects virtually every organ of the body, and therefore has many different potential effects. It works on nicotinic cholinergic receptors, which are part of the cholinergic nervous system. Basically, nicotine binds to the outside, opens a channel, and then sodium or calcium ions enter, and that activates some response. There are a number of different Pentameric nicotinic receptors throughout the body. The ones most involved with addiction are like alpha-4, beta-2, which involves alpha subunits and beta subunits. That's just more technicality, but nicotine works mostly presynaptically, so it works to augment the release of other responses. And it augments the release of many different neurotransmitters which have behavioral effects. So for example, dopamine. You all know dopamine basically is what signals pleasure, and every drug of abuse releases dopamine. It also releases norepinephrine and acetylcholine. These produce arousal, appetite control, and cognitive enhancement. Glutamate is released, which is involved in learning and memory. Serotonin is released, which is involved in mood modulation and appetite. Beta endorphin and GABA are released, which are involved in reduction of anxiety and tension. So many different things. If you ask a smoker, what do you get from your cigarette? So the first cigarette of the day is arousing, like a coffee drinker likes coffee. It helps stimulate them. If they get fatigued during the day when they're trying to do their job, a cigarette helps them focus and pay attention. If you're a baseball player in right field, you put some smokeless tobacco in your mouth, it helps you stay awake for the next fly ball. But then when you're stressed or you're anxious, it makes you feel less stressed and less anxious, and you can have a cigarette at night before you go to bed to relax you. So it does many different things. And people come to use nicotine as a way basically to optimize behavior, one concept. And then there's this nicotine addiction cycle, which is the pharmacologic aspect. I'll talk more about the sort of non-pharmacologic aspect of addiction later. But the concept is you smoke a cigarette, you get rapid absorption of nicotine, gets to the brain within 15 seconds, you get effects right away. It causes arousal, mood modulation, and pleasure. Then even within the day, you develop tolerance. And physical dependence, of course, means that when you don't have the drug, you start having withdrawal symptoms. So like 40 or 60 minutes after your last cigarette, you start having withdrawal symptoms. And then you have a craving, and you use nicotine to self-medicate withdrawal symptoms. And this is the classic drug dependence paradigm. The other thing that happens over time, though, is that the brain adapts to the effects of nicotine, and so there's tolerance and there are new neural circuits laid down. So the brain actually does change over time when the person becomes dependent. And also this paradigm doesn't cover all smokers. So 25% of smokers are non-daily smokers. And they probably smoke not so much for the relief of withdrawal symptoms as because of perceived positive effects of cigarette smoking. So it's not as simple as just this paradigm, although this is the classic addiction paradigm. So in terms of nicotine and addiction, some key issues are, one is that other factors enhance addictiveness. So for example, in cigarettes, we know that some components of cigarette smoke are monoamine oxidase inhibitors. And so when you release dopamine from the brain, if you inhibit monoamine oxidase, you get more dopamine effect. And so that seems to enhance addictiveness, not just nicotine part. And of course, as you all know better than I do, there are a lot of social, economic, and sometimes political factors that also influence who becomes addicted and who doesn't. One thing that to me has been very impressive is that at one time most physicians were cigarette smokers. And then when the reports came out about the health effects, they all quit smoking pretty quickly. Nurses at the same time were also heavy smokers, and they didn't. And the question is, what's different? Well, there are a lot of social and other factors involved in addiction besides just the drug effects. So, in terms of rapidity of nicotine absorption, quite a bit of our work now involves looking at electronic cigarettes and comparing them to cigarette smoking. And this is an example. These were from one study where we're comparing dual users and looking at effects of cigarette smoking versus e-cigarette alone in dual users. These are 3 dual users showing nicotine concentrations. The red circles are cigarettes, and the blue are the Juul pod. And you can see, if you look at number 3, you see that in that case, the nicotine profile from a Juul pod is exactly the same as a cigarette smoker. But you can also see there's a lot of variability. So number 1 got a big boost from cigarette smoking, but did not very much from the Juul. And number 2 got a lot from Juul, not from cigarette smoking. So you can see there's a lot of individual differences in self-administration, which can also affect addictiveness. So we think that the faster rate of rise is more addictive. So the speed of nicotine delivery is a key determinant, and this, when I talk about continuum of risk, this will be an important question. And then the pattern of nicotine dosing is important. And I bring this up because, again, when we study e-cigarettes, a person smokes a cigarette, usually they take 6 or 7 puffs of a cigarette and the cigarette's gone. And they wait for their next cigarette. A vapor can take 1 or 2 puffs, and can take 2 puffs a few minutes later, and the dosing profile is totally different. And so the addiction potential could be quite different in terms of peak levels of nicotine in the brain and overall exposure. So as we think that some of these factors also influence the addictiveness of a drug. Okay, so what are the potential harmful effects of nicotine? And I do this because we'll talk about nicotine first and then talk about different products and their relative harms. So the products should all have the same nicotine-related toxicity. And so here, the first one, of course, is dopamine release and addiction. So that's clearly an issue with all nicotine products potentially. Sympathetic neural stimulation. So you get release of norepinephrine, of epinephrine, you get aroused, you get more alert, your heart rate goes up, your blood pressure goes up, you constrict some blood vessels. For example, as a cigarette smoker, after they smoke, their skin gets cool because they're constricting blood vessels in the skin. And you can also can constrict some blood vessels in the coronary arteries, for example. So these are some of the sympathetic effects. Immune suppression is something I've been quite interested in with COVID. So there is an intrinsic cholinergic immune reflex system. So when you activate certain nicotinic receptors, you suppress the immune response. And this is thought to be homeostatic to prevent overstimulation of the immune system, which we think occurs in COVID. This is one of the theories about why smoking could be protective against severe COVID. That's not resolved yet, but certainly immune suppression could be a harm. Oxidant stress, we know oxidant stress is responsible for a lot of cardiovascular disease and cancer. Endothelial dysfunction, so basically the endothelium, which are the cells that line blood vessels, are responsible for dilating blood vessels, maintaining blood flow. And nicotine impairs that. Apoptosis is programmed cell death. This is a concern in cancer because when you block that, you could potentially have cancer cells live longer. So there's some concern about cancer. And then also the promotion of cell growth. Angiogenesis, which is blood vessel growth, can also be promoted by nicotine, which could play a role in cancer and also cardiovascular disease. So these are some of the concerns we have with any nicotine product. So this is sort of my current summary about in human disease, what do we think nicotine probably contributes to? So addiction, definitely. Cardiovascular disease and reproductive toxicity, probably. I talked about the cardiovascular disease. That's mostly because of sympathetic neural stimulation. Reproductive toxicity is because of some of those effects during pregnancy, but there's also effects on brain development of the fetus, which is probably due to premature nicotinic stimulation of the fetal brain. Impaired adolescent brain development, we'll talk about that, that's possible. Infectious disease risk is possible because of immune suppression. And I would just say in animal models, if you infect a mouse with influenza and you give them nicotine, they get greater infection and they get sicker. So that's certainly a potential thing. It's not been well studied in terms of nicotine per se. Cancer, there are no good human data, convincing data about cancer, but there certainly is biological plausibility. And then the COPD, which is from smoking, I don't think nicotine plays a role there. So this is just my overview about what nicotine might be doing per se. This is not the product, just nicotine. So let me switch now to continuum of risk. This is important, obviously, for harm reduction, but also considering any future role for nicotine. So this is a slide from David Abrams, but I've modified it. And I think this is a nice way to consider continuum of risk. So on the vertical axis is addictiveness and appeal, which is important for risk because you need to take the product to experience the risk. And on the horizontal axis is intrinsic toxicity of the product. So at the upper right, you see combusted tobacco products, most addictive, and also most toxic. At the bottom left, you see nicotine replacement therapies, which are low appeal, low toxicity. And then the upper left are e-cigarettes, which are more appealing, less toxic than cigarette smoking. Then along the line itself, you would see smokeless tobacco, and I probably would put oral nicotine products there too, which are not as appealing as inhaled products, but much less toxic. And then the bottom right is something that I added to this slide that Dave didn't have before, which are very low nicotine content cigarettes, which are very interesting. So if you smoke a cigarette, doesn't matter what the nicotine content is, it's very toxic. But if you reduce the nicotine, it's not very addictive. And so we'll talk about that later, because that sort of fits in this scheme in a new way. Okay, so let me just go through the different products and the relative risks. So the highest, obviously, is combusted tobacco. I showed this slide, but I'm not going to talk about this. But besides the intrinsic risk of combusted tobacco, there's also the issues of secondhand smoke, which we know causes risk, and also third-hand smoke, which I'm bringing up because it's a big research project I'm involved with. Third-hand smoke is really the contamination of environments with cigarette smoke that persists. And there's evidence that people, especially kids, crawling on the floor, eating dust, touching things, are exposed to tobacco smoke even if no one in the house is currently smoking. And so these are all risks that are related to combusted products. I'm not going to talk about this very much, though, in terms of the main thing. I just want to mention that. So combusted tobacco for cigarettes. These are the 10 major causes of death in the US in 2016. Every single one of these is enhanced by cigarette smoking. And of course, we know the data that you've all heard that cigarette smoking causes 400,000 premature deaths per year. COVID causes twice that. It's half as much as COVID. The role of nicotine here is obvious. Nicotine is what is driving combusted tobacco use, but it's really the combusted tobacco use itself that causes the 10 million deaths worldwide. So what do we know about what it is in cigarettes that makes people sick? So this is a list of all the different things. Oxidizing chemicals are probably most important. You oxidize, you damage membranes, you cause inflammatory responses, you increase coagulation, you get blood clots. That's probably the biggest driver. Carbon monoxide reduces oxygen delivery. Tobacco-specific nitrosamines, polycyclic hydrocarbons, and numerous other carcinogens cause the cancer. Volatile organic compounds like acrolein, acetaldehyde are involved in toxicity. Particulates themselves can be damaging. Metals involved in tobacco, involves nicotine. So this is what makes combusted tobacco so bad. The other products we'll talk about next have got much less of this. And so we talk about the relative risks of different products. So let's talk about electronic nicotine delivery systems. So in my sort of risk profile, I would put this sort of this second going down. So probably more toxic than vaping. I'm not sure about that. These products are not currently marketed in the US. They are in other countries around the world, but these are like little cigarettes in like a heating device. So these devices, you don't burn the tobacco. You basically heat them, and you volatilize nicotine as well as other oils and substances in tobacco. So you get much less of the oxidant stress, much less of the combustion products, but the same amount of nicotine. So this is undoubtedly much less harmful than cigarette smoking, but the question is whether it's more harmful than vaping or not. I don't know. We just don't have enough data for that. But this is certainly the next step down, in my point of view. Then if we look at vaping, there's been a lot of discussion, I'm sure you know, about the vaping controversies. I would just say straight now that nicotine vaping is not the same thing that caused EVALI. EVALI was really exposure to vitamin E acetate that was used as an oil, as a solvent for THC. Nicotine is not soluble in vitamin E acetate, and so you would not have that exposure from nicotine vaping. So one comment that I make about e-cigarettes is that they are very different one from another. So you can have little devices like a Blue, which has small batteries, relatively lower temperature. You can have big ones like the big tank models, which have huge batteries and generate aerosol at high temperature. And then second from the left is Juul, which also has a very small battery and high nicotine concentration. So there you're basically getting a fair amount of nicotine with a very small amount of aerosol at a relatively low temperature and temperature controlled. And as I'll show you in a minute, the temperature is really critical in terms of toxicity. For these vaping aerosols, a lot of toxicity is thought to come from the thermal breakdown of propylene glycol and glycerin, which are the solvents for nicotine. So when you heat them up, you generate acrolein, acetaldehyde, formaldehyde, and other toxicants. There's also flavors that could be toxic. And as you can see here from a study where you basically look at the voltage of an e-cigarette and look at acrolein, acetaldehyde, and formaldehyde generation, there's a huge impact of voltage and temperature. So a Juul that's temperature controlled will generate much less of these toxicants than a big tank model or a mod. So one of the things about e-cigarettes is that they really vary in toxicity, and this can be regulated. And so my thought is a Juul type device, a high nicotine, low temperature device, is probably not generating a lot of toxicants. And that's important for this continuum of risk issue. Then this is something which is new. I just learned about this. There are now ultrasonic nicotine devices that are not like e-cigarettes in vapor. They basically, it's an ultrasonic generation of nicotine without PG and VG, without heating. They do heat up a little bit when you sonicate them. And so this would probably be a little bit lower in terms of the risk profile than e-cigarettes. We have no data at all about safety of these products, but these are also now marketed. This is a new kind of vaping. And then the next on the list would be smokeless tobacco products. And this is very informative because here we do have data on nicotine from smokeless tobacco from Scandinavia. So Swedish snus is interesting because, one, it's widely used in Sweden. At least 20% of men use it. And also it's regulated by the government so that nitrosamine levels are relatively low. So it's a clean product, as clean as tobacco can be. And interestingly, Sweden has got the lowest tobacco-related disease mortality rate in the world because smoking rates are so low, because they're using snus instead. So nicotine consumption is the same in the population. You get just as much nicotine using snus as you do smoking cigarettes, but the disease risk is low, which to me is reassuring in terms of the fact that nicotine itself is not so intrinsically harmful. It's also been a good way to conduct a natural experiment of nicotine without combustion. And so I'll show you two sets of data, one positive and one with concern. So for cardiovascular disease, which I'm most interested in, so again, similar daily nicotine exposure, slower absorption. So I have to say, we don't know what the risks of inhaled nicotine are per se versus oral nicotine. So this safety data assumes at least the oral nicotine. No effect on platelet activation, which is an important thing in cardiovascular disease, or carotid intimal thickness. That's sort of the disease of the carotid artery, which indicates atherosclerosis. It's measured by ultrasound, it's non-invasive. And there's no evidence of atherosclerosis acceleration in snus users. Case control studies show no increased risk of myocardial infarction or stroke, but an increase in case fatality. Why might that be? Well, again, if you have coronary disease and you have increased epinephrine levels, catecholamine, basically a sympathetic state, then that makes whatever arrhythmias you might have during ischemia more potentially lethal. So I think it's really the catecholamine effects likely to interact with ischemia. There's also a study as shown here, which is quite interesting. I think it's the same phenomenon, that if you have a heart attack and if you continue to use snus versus you quit after your heart attack, it affects mortality. So the left basically shows mortality per 1,000 patient years following a myocardial infarction in Sweden. And so if you keep on using, which is the U, your mortality is twice as high in the next, I think, 2 or 3 years. Same for cigarette smoking. Smoking is higher. So there is a potential risk if you have cardiovascular disease of nicotine use. And there's also an increased risk of heart failure, but not atrial fibrillation. That's relevant to comparing to cigarette smoke. So I think it's not totally safe, but certainly looks like it's much safer in terms of myocardial infarction rate and stroke than cigarette smoking. Reproductive toxicity is interesting. So if you look at snus users among women in Sweden, there are certainly concerns about the fetal effects on the brain. We talked about that a little bit. There's also effects in animals suggesting impaired lung development. But snus does, and this slide basically, the red is cigarette smoking, the blue is snus, and the numbers are odds ratios versus non-users of anything, of tobacco products. So you can see that for low birth weight, cigarette smoking is a huge risk factor, but snus is also a risk factor, and that's probably a nicotine effect. For preterm delivery, they're both increased and about the same. Preeclampsia is really interesting. So here, cigarette smoking is this is one of the few beneficial effects of cigarette smoking in terms of preeclampsia, which basically means hypertension and potential seizures and whatnot during pregnancy. So it's lower for cigarette smoking and it's higher for snus compared to non-smokers. So why would that be? Well, it turns out that's probably carbon monoxide. Because carbon monoxide is a vasodilator, it dilates blood vessels. And preeclampsia is a disease of vasoconstriction and hypertension. And if you give carbon monoxide, that can presumably antagonize it. But if you give nicotine without carbon monoxide, then you can get augmented vasoconstriction from the preeclampsia process. So this is what our current thought is. Anyway, so this I think gives you an idea about what the nicotine per se issues would be. So next in our toxicity spectrum are oral nicotine products. And there are now a whole variety on the market, which are probably relatively safe. These are just pure nicotine without any of the other things in tobacco products. And then the lowest on the risk are nicotine medications. So that's my sort of list of continuum of risk. So what about harm of nicotine in youth? So here's some data which I think is encouraging in a way. So the blue bars are the prevalence of cigarette smoking the past 30 days among high school students through 2019. And this is amazing progress for public health. It went from 16% in 2011 to 6% in 2019. Most recently, it's 3%. So that's really awesome in terms of high school students are just not smoking anymore. Vaping has gone the other way around. So total nicotine has stayed the same, but now many more kids are trying vaping, but they're not smoking cigarettes. And about 25% of the kids who vape in the past 30 days vape 20 days or more. So we'll talk about that later. So that's a potential concern in terms of addictive use. So maybe 5 or 6% of kids are using it in an addictive pattern. Some concerns about youth vaping is one, nicotine addiction among those who have never tried smoking. That's a big concern. The increased risk of trying smoking and renormalizing smoking. Well, that doesn't seem to be happening so far. Harm to the adolescent brain, which I'll talk about in a second. And then, as I mentioned before, as vaping is more popular, smoking is going down. So maybe some people argue there's a protective effect of vaping. So this is a paper I'll just point out to you. It's a new paper from Ken Warner, David Mendez, which tried to look at the question of, if you're a never smoker, do e-cigarettes really promote cigarette smoking? And this analysis says when you look at risk factors, that's not the case. So e-cigarette users, if there are no risk factors, do not predict later cigarette smoking. This is an important analysis in terms of dealing with the concerns that many of us have that kids who start vaping without being a smoker are going to become smokers later on. Doesn't find this in this analysis. So that's reassuring. What about the adolescent brain? Well, we know that the brain doesn't fully mature until age 25. And a key part of this maturation process with respect to adolescence is the prefrontal cortex. The prefrontal cortex is involved in decision making and impulse control and executive function. And so what do we know about adolescence? Well, there's increased risk taking, there's increased impulsivity, there's novelty seeking, there's increased vulnerability to initiation and addiction to drugs. So that's just part of normal adolescence. We know from rats, though, if you give rats nicotine in adolescence, it does delay the maturation of the prefrontal cortex. There's been some good basic biology in how this happens. Again, it has to do with activating nicotinic receptors and pruning of pathways. There are persistent changes of dopamine release into adulthood. There's an anxiogenic phenotype in adulthood. There's a persistent deficit in cognitive function, and there's a greater rewarding effects of drugs of abuse. So there's a very strong biological plausibility in animals that nicotine could affect the adolescent brain. In fact, this has been used in many anti-smoking advertisements trying to reduce smoking or nicotine use in kids. The caveats with respect to human causation, one is that the data mostly come from animals. In people, it's very difficult to distinguish the effects of nicotine and tobacco use from genetic and socio-environmental factors involved in who becomes a nicotine user in adolescence. And the third one is, in adults, if people smoke in adolescence and they quit, we don't find any evidence of persistent cognitive issues in adults later on. So I think the adolescent nicotine question is important, but it's hard to know how important it really is. There's also a question that comes up about is addiction per se harmful? Compulsive drug use. So it could displace important activities. Maybe you're using nicotine instead of playing sports. It might be interfering with school, social, and family relationships. It could be financial stress of being able to buy nicotine products. And also something which I'm concerned about is combined nicotine and cannabis use increases the dependence on both and we know there's a very high concordance of nicotine use and cannabis use. And so this could be another harm that's not directly nicotine related, but influenced by nicotine. Okay. Let me shift now and talk about cigarette smoking and nicotine-based harm reduction. So first, I talked about what happens after cigarette smoking, and I think there's some promising signs for progress in tobacco use prevention. And so here data from National Health Interview Survey in 2020. So any tobacco use is about 17 or 18% of the population. Cigarette smoking is down to 12%. When I first started doing research in this area, smoking prevalence was 35%. 12% is really awesome. California is below 10% now. So we've made a lot of progress. E-cigarette use is about 3% of the population, and you can see the other products. So I think we're making progress. But if you look at quitting rates, here data looking at interest in quitting, stated 70% from many years. Quit attempts, 50% of people try to quit in the past year. Success rates, 5%. These haven't changed over the years. So people who are smokers are still having a hard time quitting. Which brings us to the question about what can we do to make this faster? And obviously getting smokers to quit as soon as possible is essential for public health, because your first event could be a heart attack, it could be a stroke, it could be sudden cardiac death. Here's a slide that I like to show, which basically talks about the effects of prevention versus treatment in terms of deaths. So this is an old slide. It's projected from 2000 to 2050. And the yellow line is if you don't do anything. The upper dashed line is prevention. I think we're doing a great job with adolescent smoking rates of 3%. We're really here. So prevention works, but it doesn't work for like 20 years. Quitting works right away. So the question is, what can we do to accelerate quitting? So that brings us into this concept of nicotine-focused tobacco regulation. And I'm sure many of you know about this paper that was published by Scott Godley, who was head of FDA, and Mitch Zeller, who was head of the Center of Tobacco Products in 2016, where they talked about a nicotine-based framework, which basically was saying our enemy is combusted tobacco. If we can't get people to smoke without it, let's get them to use less harmful nicotine products. And so it really gets back to this risk, get them from the upper right to the bottom left as much as possible. Incentivize them to quit, or switch at least. So again, here's the scheme. Nicotine is driving addictive to tobacco use, but let's provide the nicotine in some way that's cleaner and at least reduce harm. And so a lot of you here, or several have been involved in studies involving reducing the nicotine content of cigarettes to make them less addictive. This was a study that Jack Henningfield and I published in 1994, where we talked about this concept, and the concept was really based on prevention. So we said lots of kids experiment with tobacco products. Most of them don't intend to become addicted, but in fact they do. And so let's prevent addiction in youth by saying, okay, they're going to experiment, but let's make the cigarettes less addictive if they do experiment. And we projected a threshold for addiction, which would be 5 milligrams a day, or maybe 0.2 milligrams per cigarette. And we projected a gradual reduction over 10 to 15 years. This was a scheme that we proposed. So you basically reduce the availability of nicotine from cigarettes to make them less addictive. You provide, if they want, clean nicotine as an alternative source. And then people will quit smoking cigarettes, and then they either keep the clean nicotine or stop that. This was the first scheme. So from 1994 to the present time, there actually has been quite a bit of research ongoing. The seminal study, which Jen was involved with in this study, and I was involved in others. Basically, this was the big trial that showed that if you switch people from regular cigarettes to reduced nicotine content cigarettes, all these were volunteers, one, they don't compensate, so they don't take in more toxicants. Two, they smoke fewer cigarettes, presumably because cigarettes are less rewarding. And three, their dependence scales go down. And so here's some examples from a study we did, a smaller study, but these are what some of the people say when they're switched to reduced nicotine content cigarettes. I no longer feel the need to have coffee and cigarettes first thing in the morning. I'm experiencing less craving. Smoking these cigarettes are like quitting, so I might as well quit. And smoking is losing its pleasure. So if you reduce nicotine, you can actually have a big impact on the rewarding effects of cigarettes. And in fact, in 2017, the FDA placed this advanced notice of proposed rulemaking to reduce nicotine levels in combustible cigarettes. They got lots of comments. Whether FDA will move on this or not, I don't know. We have no idea. But there have been some questions and challenges, and these are some of them. So one is that tobacco companies and others, including some public health people, argue that reducing nicotine to non-addictive level is altering the essence of a cigarette and is de facto prohibition. And we shouldn't be doing that, some people argue. Well, it depends. This is kind of a benefit-risk thing. You know, if you mandate seatbelts because they kill people, you mandate that cigarettes become less addictive. And that's a question that you have to decide. You know, I think this is a reasonable thing to do. There are the arguments that nicotine reduction violates personal autonomy and represents government overreach. And there's concern about suddenly depriving smokers of nicotine, resulting in severe withdrawal, aggravation of mental illness, and other harms. So we know smoking rates are higher in people with mental illness and substance abuse, and are they self-medicating? Is this necessary for their well-being? And I think Jen has been doing work in this area. So I won't talk about this, but here's a paper that I wrote with Eric Donnie and Dorothy Hatsukami, just saying, if we think about e-cigarettes and reduced nicotine content cigarettes, they should go together. So we should be doing both policies at the same time, reducing the addictiveness of cigarettes and making other things available and making it easier to access them. So this would be a way to deal with that. So let's now talk about other drugs. Put this in a context of other drugs. So comparative benefits. So this is my list of benefits, and I'm just curious. This is what I just came up with. Be curious what other people think about this. So for nicotine, the benefits are pleasure. There's stimulation, there's relaxation, there's mood modulation, cognitive enhancement, psychiatric benefit, we think, enhanced athletic performance. The Olympics has been thinking about banning nicotine because cross-country skiers like to use nicotine snuff when they're cross-country skiing, and there's some evidence of enhanced performance and weight control. Some of these effects obviously are reversal of withdrawal symptoms, but still occasional smokers who don't get withdrawal symptoms still talk about these things. For alcohol, there's pleasure, there's relaxation, gustatory rewards, people like alcohol. Cardiovascular health is a question mark here. And I say that it's always been thought, at least in the cardiovascular literature, that occasional alcohol is actually good for cardiovascular health. But a recent study was published in the last couple of months suggesting that when you look at other risk factors, that's not the case, that alcohol at any level is harmful for cardiovascular health. So there's a question mark there. For cannabis, the benefits are pleasure, relaxation, mood modulation, managing anxiety, depression, a sleep aid, and pain relief. So that there certainly are some potential beneficial effects of cannabis. So they all have got beneficial effects. Harms. This was a great analysis from the CDC, which tried to quantitate what the harms are from alcohol. So they looked at chronic causes, so all the diseases associated with alcohol use, liver disease, brain effects, cancer, hypertension, heart disease, and then acute causes, so poisonings, motor vehicle accidents, suicides, homicides, etc. And this is pretty impressive. So they argue almost 100,000 premature deaths from alcohol use per year. Not as much as cigarette smoking, but most likely much higher than nicotine would be, per se. For cannabis, this was harder. I've never seen data for alcohol. If anyone knows data, quantitative data in terms of risk, I don't know, but let me just make a couple comments about this. So one is we look at the products. So there's smoked flower, there's also concentrates like dab and hash oil, vaporized. But an important thing here is that the THC levels in cannabis have increased phenomenally, an average of 4% in 1995 to 15% now. So people are getting a lot more THC from their cannabis than they used to. Broad health effects are shown here. there's some potential pulmonary disease if you vape a lot of cannabis. Not a lot of data there. Cardiovascular disease can occur if you have pre-existing disease. I won't talk about that. Certainly regular cannabis use is associated with reproductive disorders and problems. And so I'll talk about the other three briefly. Acute effects in terms of toxicity, mostly in terms of what would bother me, especially with youth use, is impairment of short-term memory, judgment, attention, and coordination. So if you're stoned, you don't remember things. And that can be a significant problem if you're dealing with students who are using cannabis. For chronic neurocognitive effects, this basically involves people with cannabis use disorder, which is, as far as I can tell, 10% of users in general. So issues of cognitive decline, impaired educational, occupational attainment, impaired driving ability, emergency room visits, psychiatric symptoms, premature psychosis, other drug use, all substantial. And then social dysfunction issues as well with cannabis use disorder, poor school performance, higher unemployment, lower job income, et cetera. So these could be pretty substantial. Again, I couldn't find numbers trying to say how many people actually experience these like we do with alcohol. I think that would be an important analysis to do. Well, but what about the relative use of these drugs among high school students? So this was a very informative study from Monitor the Future. So basically the blues are past 30 days and the reds are daily. So cigarette smoking down to 3% in past 30 days, and like 2% for daily smoking in high school. That's great. Vaping was 20% and about 6%. Marijuana was about the same. Alcohol, past 30-day use was 26%. Daily was pretty low. That's reassuring. So clearly there are differences between overall use patterns and daily use patterns for these various drugs. So let me end up with the questions about, is there a role for nicotine in society? And it also goes along with this. What should be the goal of tobacco control? Should it be to reduce the harms of combustible tobacco, which is the biggest issue, or should it be a nicotine-free society? So my question is, should it be a nicotine-free society or not? And again, so this is like the doctor who talked to me in my conference. So do we respect people's rights to make the judgment that nicotine use benefits outweigh the risk, or should we just say no? So here's some considerations. First is, what is drug addiction? So the two definitions that I've used mostly are loss of control of drug use, everyone agrees to that, and a disease of brain reward centers, like driving dopamine circuits. We all agree with that. But if you look at DSM-5, tobacco use disorder, half the criteria involve impairment or distress or harm or disease. So what if you don't have that? Is that still addiction? Again, this guy who asked me the question said, I don't think I'm addicted because I'm making a choice and it's not causing me any harm. So that raises a question about what do we mean by drug addiction. Now, if you look at addictive use behaviors, they do vary across drugs. So for cigarette smoking, 75% are daily users, which would suggest addictive use. For alcohol, 10%, for cannabis, 10% have cannabis or alcohol use disorders. But the addiction risk for nicotine really depends on the product. And we think for vaping, like in kids, it's much less than 75%. Prohibition is a big issue. So, alcohol, cannabis, and nicotine have all been prohibited. So for alcohol, it was prohibited from 1920, 1933. Cannabis, the first recreational use was approved in 2012. Nicotine was prohibited in 15 states between 1890 and 1927. In all cases, it was reversed because of popular demand saying this is not reasonable, or because of rising crime and whatnot. So clearly the harms of prohibition, underground black market, illicit products with less regulation, enforcement of violators. Do we want to arrest kids who vape if nicotine is illegal? And developing another war against drugs. So what are some of the things we should think about in assessing the public health impact of non-combustible nicotine products? So I made a list here of some of them. So one is, weighing the health risks and benefits in the context of the users, their use pattern, youth versus adults. So again, benefits versus risk. Precautionary principle. So in medicine, we tend to be cautious. So if someone's got the potential risk, even if we don't know what it is, we say, let's not take that risk, if we don't have to. And we don't know, frankly, say what the risk is of 20 years of vaping. There could be lung disease, we just don't know. No one's been studied long enough. Personal autonomy. So addiction means that you've lost autonomy, but if you want to use nicotine, even if you're a compulsive user, that's free choice. And so how do we weigh those things against each other? Social equity. So who are the smokers now? People with mental illness, substance abuse. There's questions about whether this is self-medication in some sense. And so if that's the case, that's an important question in terms of what we should do about nicotine in the future. Harms of prohibition, and I talked about that. Corporate influences is important. So many people say, this is just another ruse for the tobacco company to sell more products. Tobacco companies have been bad in the past. We should not reward them by giving them more profits now with some other product. And also marketing. With cannabis, CBD became legal, and then every company now is marketing CBD. We want that for nicotine. It could happen. And then the question is, we should have broad social consensus. And that's interesting because it depends on, on cigarette smoking. So I happen to live in a county where smoking rates are very low. And there's no social consensus that nicotine should be available because no one uses nicotine. The question is, what's going to be the consensus in the country? So my summary in terms of nicotine is that nicotine has got effects on every part of the body. Basic and some clinical research suggests potential harms. Long-term non-combustible nicotine use, while not harmless, is likely much less harmful than cigarette smoking. Nicotine is potentially more addictive than other drugs, but the severity of the addiction depends on the delivery system. So it would be much less for say, oral nicotine. It's less for vaping than cigarette smoking, probably less for oral products. Alcohol and cannabis use can be addictive, and with regular use are probably more dangerous than non-combustible nicotine. And that the acceptability of non-combustible nicotine use in addiction in non-smokers is both a scientific and a socio-political question that needs to be addressed. So who decides the future place of nicotine in society? And so I would ask this group, because I'm not going to come up with an opinion, but what is the role of academics in influencing the future of nicotine? So let me just stop there, and I'd be interested to hear what you all think and what questions you have. So thank you very much.
Great, thank you. I think we have a few minutes for questions. So if you keep them short, and Neil asks you to keep the responses short. Anyone from the audience, then we'll go to Zoom webinar. Don't be shy. Joe?
Yeah. This is great and really thought-provoking. And as you were talking about this at the end, one of the things that came to mind was, I think the way we were talking about this earlier today, we just treat these things, alcohol, cannabis, and tobacco differently. One is criminalized, one is socially acceptable, one has, cigarette smoking has become less socially acceptable, but has a replacement that is sort of acceptable. And maybe the way is to is when we think about addictive substances, whatever they are, whether it's eating, gambling, smoking, drinking, vaping, cannabis, is to put this in a public health context or in more of a health context, and to think that we need to not criminalize things, and we need to think about how we manage the risks and benefits of them, more from a public health standpoint, less from a criminal perspective for some of these things like drugs of abuse, and just put a totally different framework around some of our vices, really. And maybe nicotine as a lens is the first way to look at that and apply that lens to that.
Right. Well, that makes sense, but you can see what's happening with cannabis. So cannabis is going the opposite direction, right? So we're seeing more and more cannabis being accepted, more and more cannabis being legalized. So the question is, why is that happening at the same time that nicotine is being more thought as very bad? If your kids are smoking cannabis, that's okay. If your kids are vaping, that's terrible. So why is that going on? And
so if I just interrupt for a second, I have a one-line answer to that.
Yeah, tell me.
Will you tell me? I think it's very simple. I've talked to a number of people. It's the tobacco industry. Is that people are so busy hating the tobacco industry, that's all we think about. We don't think about nicotine or anything. There's no sort of marijuana industry, right? There's a tobacco industry with a long history of lying, killing people, manipulating the data and so forth. I think we just get obsessed with that. And then I think that's my answer. I don't know if I'm right or wrong. I can't come up with any other answer.
That's certainly a big factor.
So from the audience here, is there any data, in brief again, on tobacco-free nicotine pouches like Zyn on those products?
Well, there are data about its pharmacologic effects. There are no health data. We know from nicotine products that you can have GI upset, you could potentially aggravate ulcer disease just from swallowed nicotine. But there really are no health data yet on oral nicotine products.
Oddly enough, I was asked to review a paper, God knows why, because it was in like drug and toxicology, it's a Eurojournal. And I reviewed it, and it compared, not in vivo, but just simply Zyn or on, I think it was on actually, on versus nicotine gum on various sort of factors, looking for formaldehyde and all these things, just as clean as nicotine gum, just as clean on every factor. So that's just not even in vitro, that's just a product analysis.
Yeah.
But there are people doing these studies. We're doing one here, randomizing people to e-cigarettes and nicotine pouches. So more work does need to be done. There's another question, why do we not use nicotine-like structures to simulate dopamine secretion by dopaminergic neurons to cure Parkinson's diseases or slow down the Parkinsonian process?
Well, that's interesting. So Abbott Pharmaceutical Company was developing nicotine analogs for pain and also by considering Alzheimer's dementia. And they stopped it because of potential cardiovascular toxicity. So I think there were some issues of atrial fibrillation. So the question there is you would need to be able to develop nicotine agonists that are really brain selective without having cardiovascular effects. So I think that's something that there's potential to do that, but I don't know of any companies now that are doing that. But I think that's a possibility.
To put you on the spot, which I enjoy doing, did you answer your own question? Do you feel there's a role for nicotine?
Well, I think in my comparison, like I said in my summary, I think nicotine looks favorable with respect to other drugs. The question is, what do we think the role of drugs should be in our society in general? Should we discourage all drug use, in which case nicotine should go along with it? I think most people would accept alcohol use, most people now accept cannabis use. If you do that, then the question is, why do we want to single out nicotine? So I don't find a good reason for doing that, but many people disagree because they think that people want to stop smoking, let's just stop nicotine as well.
Or another way to say it, maybe translate what you're saying, maybe you could do an op-ed or something like this, is that if we're accepting alcohol and we're accepting cannabis, we almost have to logically accept nicotine from a scientific perspective.
Right, we do, but again, where I live, which is an affluent community, a lot of people drink, a lot of people use cannabis, and no one uses cigarettes. They say, we don't need nicotine. So it depends what population you're dealing with.
Suzanne?
Yeah, it just makes me think, I mean, in your community, yes, but this is a big, diverse country.
That's right, exactly.
And it's a country that's allergic to government overreach, and there can be quite violent response to that. So it seems like the form in which nicotine is being used is the most crucial thing. And so I'm curious because you know a lot of the players, as government agencies look to enact a nicotine reduction policy, if they do, it seems to me that would go down a lot easier if we had a ton of other safer alternatives or lower risk alternatives for nicotine delivery than trying to do a broad nicotine reduction across products, which I know has also been discussed.
Oh yeah, I absolutely agree. In fact, I think it should be the opposite. I think that the products should be better nicotine delivery systems than cigarettes. So the tobacco and health people who are opposed to nicotine reduction think that alternative products should be competitive with cigarette smoking, so people voluntarily switch. I don't think that's going to happen. I think cigarettes are just intrinsically more addictive. So you need to make cigarettes less attractive and give them easier access to nicotine from other products.
And then I mention the F word, flavors. Because if the appeal of the alternative products is higher, it's going to compete better with combusted cigarettes. And so taking away flavors from safer products just seems misguided.
Yeah, well, that all, as you know, so that all has to do with kids. And because a lot of kids start using products because they taste good, or their friends say, this is really fun to use because it tastes good. They try different flavors, and so the question is, can you control youth use and still allow flavors? How to do that best?
Right.
We don't need bubblegum flavors, all the child flavors, but I agree with you that having a few reasonable flavors would be a good idea for adults in general.
Went with one of our students.
Hi, can you elaborate more on the device that reduces the harm of combustible cigarettes and provide insight for why it might be appropriate in the US?
Are you asking about IQOS maybe?
Yes.
Yeah, IQOS.
Yeah, so that's a really interesting issue. IQOS was approved by the FDA as a product that had got likely reduced harm. The reason it's not here yet has to do with lawsuits between two companies arguing about bringing the products in, so it's going to be here sooner or later. But in some countries, in Japan and South Korea, these products are very widely used. In Europe, there's a fair amount of use. It'll be in the U.S. I don't know when. Jazz, you know anything more about
so just technically, Mitch would cringe if you use the word approved. You know that.
Yeah,
he
not
was
authorized.
Authorized. Mitch is, of course, retired, so who cares what much things. But IQOS was here. It was available in Atlanta and Charlotte, as you know, and then the litigation between BAT Reynolds and bans it from being. It's manufactured by Philip Morris International, but the word on the street, announced by the CEO of Ultra a few days ago, is IQOS will be back. It's hard to know who's going to bring it back. It appears that they're going to manufacture it in the U.S. PMI has the ability. It's their product, so they will manufacture it. Whether they'll license it to Ultra or not, who knows? It'll be back, and then you circumvent the patent infringement importation issue. I have no idea why I'm not a lawyer, but it'll be back big time because it's revolutionized Japan. I think these cultures are very. Japan is a very tech-savvy kind of country, and IQOS is a very techy kind of product, but it's taken off like wildfire. Plummeting rates of smoking in Japan.
Yeah, and one other thing about Japan is that they banned vaping because it was like a drug, but they didn't ban IQOS or IQOS-like product because they were tobacco products. So you could market them in Japan. You couldn't get vaping. So that I think explains why it's so popular.
It's fairly related to sort of end to think that I always end all my talks that science should inform policy, but it's much more complicated than that. And Japan's a good example because the whole thing about banning vaping, which I think, and it sounds like you do too, is a bit safer than IQOS. And it's actually related to, I don't have expertise in this area, but related to their taxation ministry, their finance ministry, and their health ministry, and sort of the politics behind what's a tobacco product and things like that. So these very odd idiosyncrasies across countries of why things are where they are. Like the European Union bans snus, which is unbelievable. And Sweden, I guess, is not part of the European Union. I can't remember.
Not yet, but they could be.
Well, thank you so much, everyone, for coming.
Thank you all.
Thanks for everyone.